Hello, people. Can I see your faces while we're warming up here? Be nice to know there are people behind these names. Come on, show me your faces. There's Kaylee Parker. Hi there. Sabrina, hello. Oh, Kelly Parker's gone already. Austin Armstrong. You're a good man, Austin. Haley Smith. The myth, the woman, the myth, the legend. Haley Smith. Here she is. Sabrina. The Good Witch, right? Sabrina the Good Witch? Yeah, I thought so. Grisbel Pena. Do you have a tilde over your N usually?
Yeah.
Yeah. I still remember that from Spanish class. You know, in Italian, they do the same thing, except it's GN, gives you that same nya kind of sound. And that's why lasagna sounds like it does. It's GN. Just saying. Rhoda, who's Rhoda? Rhoda, come on up. Let's see her face. She's not going to. That's okay. Alexis Menzel. I don't know any of you people. There's Alexis. How you doing?
I'm good. How are you?
I'm hanging in, you know. Do what you can. So I'm waiting to see if the speaker has shown up. I thought he'd be on already by now. Let's keep our fingers crossed. I'm going to get a telephone and see if I can call. Okay. I'm going to call Dr. Parker and make sure he knows that he should be there now. Oops. Peter Ashfeld. Who the hell are you? Put your camera on. I will kick you out of this class if you don't put your camera on right now. I don't have that kind of power. There he is. Peter. Oh my God, Peter. I love the lighting in your room there.
Thanks.
Can I move in with you, or you got roommates already?
I got roommates already.
All right, never mind. Never mind. I don't think my wife would like it anyway. Mallory. Who the hell is Mallory? Put your video on, Mallory. Ah, there she is. Oh, there's Joel Parker. Yay, Joel Parker's there.
Unmute. Yes, there we are.
So I'm going to be able to see this, or actually,
You're going to have to watch it off this. Yes,
Yeah,
so what we're
all
going to do, what we'll do is, oh, wow, a lot of people here. Okay, I'm going to get the projector up. Hey, we're actually going to get on time race, basically. So what we'll do is you go to share screen, then I'll click on the screen that has your PowerPoint, which I'm not seeing at the moment. Let's go find your PowerPoint again. Hang on a minute. So you think you can run it off this?
Sure.
Okay, so we'll try sharing that. We'll see if it works. If it
It's up
doesn't, then
top.
we'll go and we'll, yeah, so So I click, switch you to hit share screen, and we'll just click on that, and you should be good to go. Let's see if it. All right, is everybody all right on Zoom? Can you all see that?
Very nice.
Very nice. Okay, so then he can click that. What's your last name? I gotta introduce you.
Menia, and I can introduce myself.
Okay, Todd's gonna introduce himself, so we'll see how this goes. All right, good luck.
So it's recording and ready to go?
Oh, let me make sure it's recording. That's a good point. Let me, hang on a minute. Almost forgot to make sure we're recording.
Recording it. It's fine. I'm recording it here, so we're good.
So you got a recording going? Good, all
So
right.
Don, are you gonna still need me to send you a copy then? Because I don't know how to do that.
Nope, definitely not. I'm getting
Okay.
my computer here.
All right, perfect. All right, so I don't know if this is how many we're gonna get, but I think it's time, right? What time is it? All right, guys, so we'll get started. So Dr. Slish asked me to come in and talk to you guys as a guest speaker, which I guess is what this whole class is. My name is Todd Menia. I tend to pace. I guess if I get too far away, remind me because I need to be in front of this thing today. I'm an emergency medicine physician. I practiced emergency medicine for 25 years. I actually am a full-time teacher now, okay? And I decided today so that what I would do to show you guys is one of my medical terminology presentations for a couple of reasons. One is that I'm actually going to be teaching this class next semester here, medical terminology. It's going to be the first time it's been offered in a while, is my understanding. And also because I chose one of the presentations that has to do with trauma. Okay, so I want to explain to you guys how this works, because I thought trauma might be more interesting to you guys. So you would have missed some of the initial presentations at this point. And what I do is I teach a class that's based on the way healthcare providers really talk to each other in the hospital or in the clinics, okay? You learn real terminology more than just lists of words. And I always use a case to present much of the terminology. Sometimes, such as today, it's a relatively short case in terms of the presentation. Sometimes the case may take the entire presentation and you learn the terms that come through that case. So for instance, to start here, I will let you know that a routine medical evaluation, do you know, does that dinging mean I'm doing something? Oh, okay. So what you would have had prior to now, were you in the class, is I would have taught you the process of a routine medical evaluation, which for any of you who have seen a healthcare provider, a doctor, a nurse, a PA, then you've been through this process. It'll make total sense to you. You walk in and somebody at the desk says, "What can I do for you today?" And what you say to them is the chief complaint. That's what that's called. Okay, it doesn't mean you're a complainer. It just means that that's why you're there, to see that healthcare provider. Then that healthcare provider is going to go and obtain a lot of history as to why you're there. And it depends how much medical history you have and how old you are, how much history there actually is. There's social history, family history, medications, allergies, etc. But after the history, then the exam happens, right? So the physical exam is where the healthcare provider attempts to get objective evidence of what you said. What is really wrong with you? When you walk in with your car and you tell the mechanic, "I hear a clunk," the mechanic may be thinking of 3 or 4 things that clunk may be, but they need to actually look at your car to figure out what you mean by clunk. And so that's pretty much what a medical doctor does as well. So that starts with what's called a constitution. Constitution is your first impression of the patient. So for instance, if you had a patient who had just got shot in the head, one constitution could be a patient walked up to me and told me they had just been shot in the head. And that's what I saw. That was my initial impression of the patient. Another impression of that patient may be, I walked into the room and found someone lying in a puddle of blood. And that would be a different constitution. That would give you a different impression as to what you were dealing with. After that, the most important thing is vital signs, and then the routine physical exam where you actually examine the body. If you know what's going on at that point, you go right to diagnosis. Sometimes it's very simple. I have a cut on my thumb from a broken glass in the sink. And you look at them and they have a cut on their thumb. So you already have your diagnosis and now you're on to treatment plan. But sometimes after you get your history and you do an initial evaluation, you're not sure. Is this influenza? Is this COVID? Or is this the common cold, rhinovirus? And so you might need a test to figure that out. You have a differential diagnosis. That's what that's called. I have a bunch of different diagnoses that I need to narrow down. It's literally called the differential diagnosis. And any test that I get to determine what the actual problem is an ancillary study. It might be a nose swab, it might be a blood test, it might be a colonoscopy, it might be a biopsy, it might be an x-ray. So you obtain those tests and then you verify your diagnosis and you move on to your treatment plan. So that's just kind of catching you guys up. And so now I'm going to tell you about the only time in my career where a patient walked up to me and said, "Hey doc, I just got shot in the head," okay? Because that only happens to you once in your life on average, okay? So let me get the setting to you guys. So the setting is that I'm an intern, which is true. Places where you learn medicine are all in large cities and they're big hospitals because you need to have a lot of patients so that the healthcare providers can see a lot of people and learn a lot of stuff. Now, typically what happens is ambulance patients don't come in the same place that people with a cough come in. People with a cough walk up to a desk and someone says, "What can I do for you today?" But ambulances that are out in the community picking up patients, they call the hospital, they call the emergency department medical control. The medical control may be a nurse, maybe a physician, maybe a paramedic. They're going to respond to the needs of those EMTs or paramedics out in the field, get report about who's coming in. The ambulance is going to come into a separate place, an outside entry, and they're going to roll the patient in on a gurney, pretty much always, okay? Patients don't walk in from the ambulance bay. Even for like litigation purposes, they're not allowed to, okay? It's kind of like being rolled out of the hospital in a wheelchair. I know you can walk, but we don't want you to trip and fall on our property, okay? So anyway, I was an intern, which means first year of residency, which means even though you think you know a lot because you graduated from medical school, you don't know much of anything, all right? And I happened to actually be near the ambulance bay doors, and I hear them open up. But I knew there was no ambulance supposed to be en route, so it surprised me, and I looked up, and this young fellow, maybe 21 years old, saw that I had a white coat on, and walked up to me and said, "Hey doc, I just got shot in the head." So that's a pretty surprising thing because most people who are shot in the head don't walk in. The kid was actually polite, no visible sign of injury or anything like that. So I was a little bit flummoxed, you know, because that's pretty strange. And I said, "Well, can you show me?" Because I'm thinking, is somebody playing a medical joke on me, right? Was this some kind of strange ricochet? Did the guy get hit by a spitball? I mean, I don't know what actually happened here. And he points up here on the right side of his head, and I kind of pull his hair up a little bit, and there's a little bit of clotted blood right there, a puncture. So at that point, I take him and I sit him down on a gurney, and I go to the chief nurse and I say, "Could you guys do routine triage, get some vital signs and get some history on this young fellow? He says he got shot in the head and he's got a hole there," okay? And I walk over to my attending physician. So the way this works is you have medical students in the hospital, you have interns whose first year of residency, you have residents, you have chief residents, sometimes you have fellows who are people who finished their residency but are specializing in something else, and then you have the attending. The attending is the person who's no longer training anymore, so they're essentially the boss of that environment. So I walk up to the attending and I'm like, "I just brought a guy in who said he got shot in the head." You know, and he's like, "Oh, take me over there right away." And I'm like, "Well, the nurses are talking to him. It's that kid sitting over there in that bed," right? So that is the lead into this. So then what I would do is I would go in and I would tell you guys, I would go through these terms. These are the ones you need to know. ED. In this scenario, that does not stand for erectile dysfunction, okay? In this scenario, that stands for emergency department, okay? ED medical control refers to the person who is taking report on the ambulances coming into the hospital, okay? Gurney is a wheeled stretcher that patients are moved about in the healthcare setting, usually in a hospital, but also an ambulance. Now, GSW, it means gunshot wound, okay? That's a standard abbreviation for someone who was shot, okay? Now, I want to tell you what the difference between a chronic medical condition is and acute medical condition. So, chronic means persistent and ongoing, chronic. So, someone may have chronic high blood pressure. Someone may have chronic diabetes. These are typically things that once you have them, they don't go away. They're there for a long time. They tend to kind of wax and wane. But acute means sudden, and usually severe. It mainly means sudden, but an acute medical condition is used in reference to something more severe. So for instance, you could get stung by a bee, but your fellow healthcare provider would not come up to you and say, I have an acute bee sting. It's just not serious enough, even though it is sudden, right? But a gunshot wound is acute, okay? So for instance, here we look at a chest x-ray of a gunshot wound, and this is the bullet portion, okay? Now, interestingly, and I do go over a lot of imaging with my students during the terminology to show cases. An interesting thing to know about plain film x-rays, what people routinely call x-rays, is that you always need 90-degree views to know what's going on. In this view right here, we can see that what looks like a bullet is on the right side of the chest. The convention is that it's always as if you're looking at the patient. Okay, so this is the right side, this is the left side. Okay, this is the heart. These are the diaphragms separating the thorax or the chest from the abdomen, collarbones, and bullet. And we actually see these sometimes. Sometimes people who were shot a long time ago don't even remember to tell you they were shot. And you get an x-ray and you walk back and you're like, there's a bullet in your chest. And they're like, yeah, it's been there for like 20 years, you know? Things that are inert or metal don't actually have to be removed. Plant material always festers and gets infected. It has to come out, okay? But anyway, where I was going with this image is, we see a picture of a bullet here. That bullet could literally be taped to this guy's t-shirt. You don't know how deep it is until you get the 90-degree view. You have no clue. It could be here. It could be anywhere across this plane, right? So that's just a little thing. But when I give this medical terminology, I always throw in the standard slang as well. So you guys learn. I want you to be able to stand in the emergency room and understand what people are saying. So a gunshot is acute, okay? Now, when you look at actually a cartridge, which is what these things are called, there's multiple parts here. The casing right here. Inside here is gunpowder. This is the bullet right here. So what happens is there's a hammer that hits the back of this casing, sets off a tiny charge, causes the gunpowder in here to explode, shooting this bullet out the barrel. The casing comes out of the weapon on the top, on the side, on the bottom, somewhere else. So when you watch movies and you see stuff going, those are the casings flying out. It's only this piece that actually goes out to hit something like a person. This is usually lead, okay? So in terms of hospital slang, acute lead poisoning basically means gunshot wound, okay? Any questions about any of that? Okay. All right, so we're done with the history. Now the exam, again, the whole point here is to throw terminology into the process here. On the exam, there's different things we can do, okay? We can look at the patient, that's called inspection. We can touch the patient, that's called palpation. And we had already gone through these by the time we got here. You can tap on the patient, that's called percussion. What did I leave out? Did I say auscultation, listening with a stethoscope? So anyway, those are the four main things that you can do, right? So when I inspect this patient's wound, up here on the right, I have to define where this is on the chart, right? So I call this a frontoparietal wound because it is right between the frontal portion of the head, which we call pretty much the forehead. It's named for the underlying bone, which is the frontal bone. And here's the parietal bone. We have one on each side, okay? So this wound would be in the, now this is the opposite side. In real life, it was over on the other side. The right frontoparietal region of the head. I can see a little bit of swelling there, which we call edema. Edema means tissue swelling due to excess fluid leakage. Interestingly, capillary leakage due to inflammation is the main reason that people who end up being intubated from COVID get intubated because they have inflammation and fluid leaks into the little sacs in their lungs called alveoli, okay? So here we see a little bit of edema, okay? Normal, swollen, that's actually called edema, okay? So I also want to make some things clear. At this point, I would go ahead and say, well, there's connective tissue structures in the body. We hear about ligaments, we hear about tendons. We don't necessarily separate them we hear about sprains and we hear about strains, but we don't necessarily separate them. A ligament is a connective tissue structure that goes from bone to bone, okay? And when you injure that, that's called a sprain with a P, okay? But when a tendon, which I can't see under here, let me see. Here we have, did I shut, so I just got rid of that, okay. So here we see the muscle coming through and attaching to bone. So that's a tendon by definition. And when you injure that, that's called a strain with a T, okay? There are some special tendons. Most tendons look like a piece of rope, okay? They're maybe a little flatter than this, but they kind of look like this, tendons. As a matter of fact, you know, when you're eating a drumstick, there's that one gnarly piece of tendon that you try to bite the meat off of, that's a tendon. That's where that muscle attached to the bone, okay? But some tendons are wide and flat, and these are called an aponeurosis. So right here, we have a large, wide, flat tendon. Tendons are made of dense connective tissue, which is really dense and really strong, really more than you would believe, okay? And the reason I tell you this is because I did the physical exam and was still flummoxed on this guy because on palpation, I could not feel any foreign body. I could not feel a bony step off. I mean, we get assaults where people are hitting the head with a hammer and you can feel the divot in their head. You can feel the edge of the bone. You can feel a step off of the bone. So typically if a bullet went through the skull, you'd be able to feel a step off there too, but I couldn't feel anything. So I ordered an x-ray, which happened to be a CAT scan. Okay, and I would teach you the difference between CAT scans and MRIs and ultrasounds and regular x-rays and all that kind of stuff throughout the process. And when we got the CAT scan back, the radiologist reported that there was a bullet on the left frontoparietal region of the person's head. Now, I have to say that I did not palpate that side of this patient's head since he said he got shot here and that's where the wound was. And what had actually happened is, I'm going to go into some ballistics here in a second, but he was actually shot with a handgun from a fair distance. He kind of described it as from here to the wall. And also it was coming very tangentially to his head. And what happened is it went through his skin and underneath this aponeurosis, but not through his skull bone. And it rode all the way around the back of his head and got stuck right here on the other side. So here's an x-ray right here showing a bullet in the scalp, but not within the skull. And that's what actually happened to this guy, okay? So those are the ancillary studies. In this case, is a CT scan. The treatment required making an incision and removing the bullet. And he actually would get to walk home. But not until he makes a police report and not until the chain of custody form is filled out, okay? Now that bullet that comes out of this person's head is now evidence, and therefore chain of evidence needs to take place. So there's a form that hopefully, if everyone is ethical and moral, every person who touches that bullet from that second forward, including myself, signs this form. So where that bullet is and who has that bullet is known every second of time, okay? So that no tampering can occur. In regard to a police report, that is a legally reportable incident, someone being shot. Now the police can come and this individual can choose to not talk to the police. That's fine, that's their choice, but we have to report that as healthcare providers in New York State. Any questions about any of that? Okay. All right, so that introduces trauma. Now that was a relatively short case. I have some cases that by the time we work our way through that, you've got 40 new terms, you know, something like that. But now I actually use that to introduce trauma, which I want to go over with you guys, okay? Now that happened to be penetrating trauma. Let's talk about the difference between blunt and penetrating trauma. Because in the big picture, when you talk about trauma, the word trauma stands up here and then it goes blunt or penetrating, okay? That's how it starts. Blunt trauma is being hit by a flat-ish object or landing on a flat-ish surface so that something does not actually penetrate your body, even though you indeed did suffer trauma. The most common blunt trauma would be a motor vehicle crash. A more severe but less common blunt trauma would be being hit by a train, okay? The most common forms of penetrating trauma, which means that the object actually penetrated your body, no big secret there, right, would be to be either stabbed or shot, okay? And so for that reason, in terms of slang, knife and gun club is common emergency department slang referring to an emergency department that sees a lot of stabbings and shootings. So for instance, the hospital in this town, CVPH, is not a knife and gun club. If someone comes into this hospital stabbed or shot, that gets people's attention. Cook County in Chicago is a knife and gun club. They deal with people who are stabbed or shot daily, okay? So when you're like deciding where you want to do your residency and you say, oh, I want to go to Cook County, some might say, hey, that's a knife and gun club. You might say, yeah, that's what I want to see. Okay, that's your choice. But that's what that means, and that's slang. In terms of complexity of evaluation, blunt trauma is infinitely more difficult to evaluate than penetrating trauma. If someone gets in a car accident and say they take a steering wheel to the chest, they still can break their neck. They still can hit their head on the windshield and have an intracranial bleed or a concussion. They still can have a hip fracture. They still can rupture their spleen, right? But if someone is stabbed with a knife, which is a low energy weapon, which is what we're going to go into next, their injury is going to be in the path of the blade. That's it. Now, it depends if the person wiggled it around or any of that kind of stuff. But if they get stabbed in the abdomen, they can't have a concussion, right? They can't have a ruptured spleen because it's over here, you know, and stuff like that. So penetrating trauma is way easier to evaluate in the emergency department than blunt trauma is much more difficult to evaluate than penetrating trauma. But sometimes penetrating trauma, particularly in the form of a gunshot wound, can result in more distant injury. And that's kind of the interesting thing I want to talk to you guys about right now. So when I was a kid, a dumb kid, you guys might be smarter kids than I was. And of course, when I was full of testosterone, when I was a teenager and in my early 20s, and now I know better and I don't have as much testosterone, unfortunately, and I'm not 20. But back then I used to think, okay, so you get shot and this little thing goes through your body. And I'd be like, it's not going to kill me. I'm way too tough for that. You know, that's why until I went to med school, which was about 10 years later or something like that. But let me explain to you guys why being shot is so dangerous. Because in the end, usually the bullet part is actually pretty small. And to put this into perspective, this guy we talked about, which was a real case, was super lucky. Okay, that's not the way it usually happens. So whenever you are hit with something, okay, whether this trauma be blunt or penetrating, it doesn't matter. The energy of that object goes into your body. And maybe that sounds boring, right? But if you play pool, you see that. You hit the pool ball, and when it hits the other ball, the energy goes into the other ball and it takes off. Okay? The energy that is within that object is based on two factors, mass and velocity. That equation is half mass times velocity squared. So the velocity actually means more than the mass. But of course the mass matters. If I had these two objects and I was standing 5 feet away from you, if I wound up with a ping pong ball and threw it at you, you might just snicker. You might blink, maybe not even. But if I wound up with a pool ball from 5 feet away and threw it at you, you would duck and cover. Because a lot more energy is going to get transferred to your body by that pool ball because of its mass, okay? But velocity matters a lot. These are paintballs. They don't have a lot of mass, and they're pretty small, but they have a lot of velocity. So if any of you have ever played paintball, it actually just hurts quite a bit to get hit by a paintball. It's not the end of the world, you know? But this is not an unusual paintball bruise. This isn't an ER case. This is just somebody who was playing paintball. So you see the impact of velocity. This I had to show you to give you a better sense of this. This is the Canyon Diablo meteorite. It's probably a little bigger than a football. I mean, I don't know for sure, but you can see the writing here. This is what it did, okay? Because it was coming in at multiple thousands of miles an hour when it hit the ground. Its mass was relatively small for hitting the earth, but its velocity was so high that it created a crater that big. So let's talk, so that's ballistics, okay? And that explains to us why someone can get shot with a handgun, particularly tangentially, and survive, okay? But people who are shot with a sniper rifle, if they call it center mass, a .50 caliber bullet is big and heavy and going really, really fast. Some bullets go twice the speed of sound, okay? So a sniper rifle that hits you between here kills you. Anywhere in there kills you, okay? Because the energy of that weapon, the energy of that bullet gets transferred to your body, all right? So that's why this is worse than this, and this is worse than both of them, because you got velocity and mass. You don't want to get hit by that thing. You'll just be atoms, okay? So a projectile in penetrating trauma that goes through your body creates two cavities, okay? It creates a permanent cavity, which is literally the hole made by the object going through your body. And it's only as big as the projectile itself, like a bullet. So really, in that case, it just matters what it hits in terms of what it's going to damage, for the most part, right? Far worse is what's called the temporary cavity. Okay, the temporary cavity is the cavity created by the energy of that bullet dissipating into your tissue. That temporary cavity only lasts hundreds of milliseconds, okay? But that energy disperses through, vaporizes, and liquefies the surrounding tissue, sometimes 30 times the diameter of the bullet itself, okay? Now, what you see here is an example, and I'm going to show you if it works, I hope, a live example. Here we see the leading edge of the bullet. This whole thing is the energy of the bullet being dissipated into tissue. This tissue is being destroyed, okay, liquefied, even incinerated, okay? So I don't want to get too graphic, but this is basically when someone is hit with something like a 50 caliber weapon, and you see stories of people looking at entrance and exit wounds, not with rifles. There's usually nothing left if you're talking about something like a head, okay? All right, so what I want to do to emphasize, I'm going to show you a bullet going through ballistic gel. That's what this is. It's meant to be the consistency of a human, okay? And I'm going to show you some of this video. We're not going to watch the whole thing. The very first video shows the bullet going through like from front to back, okay? It's a little hard to appreciate, but you're going to see the gel go like this. And that's the energy of that bullet destroying the gel. And then you're going to see it go back and forth, which is actually what happens in your body. Then we're going to see the side view, which looks like this, which is going to be much more easy to tell what's going on. Oh, that was a little bit loud, huh? So this, what you're seeing is purely the energy of the bullet dissipating into that gel or tissue. This side view you're about to see is even better. At the end, you can see the permanent cavity, and you're going to see gas come out where this stuff is incinerated. Watch the end. You're going to see a puff of gas. The heat just from the energy of that bullet destroying tissue. Now you can see some of the permanent cavity. All right, one more time, side view, because it's the most clarifying. This really points out to you how bad gunshot wounds are, okay? Okay, so point being, when I was a bozo teenager and I was thinking that little bullet's not going to hurt me, well, if that little bullet didn't hit a vital organ and its permanent cavity was therefore through a safe place, yeah, that part of it wouldn't have killed me. But if it went through here, my liver would be gone, My intestine would be destroyed. I wouldn't be able to absorb nutrients ever again for my life. You can't live without a liver. Who knows? God knows all the way down to my bladder possibly, right? So penetrating trauma, all types of trauma, transfer energy to your body. This is why gunshot wounds are so much worse than stab wounds, okay? But there's always other factors for how we manage trauma, okay? For instance, the vector of force, right? So if this Mercedes T-bones into this SUV, the most energy is going to go directly into that SUV at about ankle level of this person. But when this SUV, which also has greater mass, T-bones this Mercedes, this energy is going right into the driver of the Mercedes chest. That's where the vital organs are, okay? So vector of force matters. That's why vehicles are built with crumple zones, okay? So the crumple zones are put there on purpose. When the vehicle hits something head on, it kind of crumples down and takes some of that energy out of the impact before it gets to you. But if you're driving a motorcycle and you get ejected, there's no crumple zone and you're going to suffer a deceleration injury, okay? Injury resulting from a fast-moving object suddenly slowing or stopping. The old joke about the fall doesn't kill you, the sudden stop does, of course, is completely true, right? Well, there are anatomical considerations as well. So that's the reason that you need to know anatomy and physiology. Okay, you guys, if you've had embryology or neonatology, I'm not sure what you would take here, but when you are a fetus, the blood coming from mom comes into your heart and comes out this pulmonary trunk. The problem is that pulmonary trunk goes to the fetus's lungs, which are not inflated. So there's a lot of back pressure. And so there's a little tube here called the ductus arteriosus that takes that blood to the aorta so it can go to the baby's body. But when you're born, that shuts down because your lungs open up and it becomes a ligament arteriosum. The ligamentum arteriosum actually connects the aorta to the pulmonary vessels. And the heart is relatively fixed. So when you stop suddenly, your aorta tears. Now, when I look at these words, deceleration injury, then we learn what's called a combining form. Arterio refers to artery, arteriosclerosis, right? So anytime you see arterio, it refers to an artery. And an artery is a high pressure vessel. Those are the vessels that come out of your heart, okay? And that's your blood pressure, 120/80, a lot of pressure. That's different than a vein, right? Veno is the combining form for venous structures. Vein, of course, is the main structure. Veins have almost no pressure. As a matter of fact, we have to have mechanisms in our body like muscle contraction and stuff like that to push that blood back up to our heart. So when you consider the fact that this blood in this aorta, which is the biggest artery in the human body, all the blood directly from the heart is going out that artery. If that artery tears, that is not a survivable injury, okay? So the average person pumps out about 70 mLs of blood per heartbeat. You would never need to know these numbers, okay? The average heart beats about 70 times a minute. So 70 times 70 happens to be 4,900. Let's call it 5,000, 5 liters, which happens to be the amount of blood in the average human body. So that means that when you tear your aorta, all of your blood comes out in 1 minute. Okay, so this is not a survivable injury, all right? I actually took care of one kid. Sometimes you can partially tear it and the connective tissue is just holding on. Some blood is leaking out, it's clotting. I actually had a young guy with a deceleration injury. I don't know if you remember the old Cutlass. There were some old cars back in the day, probably before you guys were born. The rear windshield was straight up and down. This guy happened to hit the back of this car and pancaked right against that windshield. Came into the emergency department complaining of severe chest pain. I was suspecting this problem. We rushed him right to the operating room, but he actually ruptured on the way, completely ruptured on the way to the operating room. He did not survive that. Very sadly but true, when I went out to talk to his family, that was the second son they lost from a car accident or a motorcycle accident. Pretty horrible. And that's why they call motorcycles donor cycles, okay? I actually had both street bikes and dirt bikes. I'm not anti-motorcycle, but you need to know the risk you're taking when you're on one of those. This is slang. Donor cycle refers to the fact that people riding motorcycles very often result in fatal head injuries, but the rest of the organs are still available for donation. Okay. Any questions about that? Bonus slide. Okay, so I guess on this one, this is when I just tell you some other stuff, but there's no terms that you're going to have to remember. All right. So there are factors such as, of course, where you're injured. Even though a knife has essentially no temporary cavity, you're only dealing with the permanent cavity because there's not a lot of energy. However fast you can stab someone is insignificant compared to the speed of a bullet, right? But as we said, if that knife happens to hit your aorta, that's still going to be a fatal wound, okay? That permanent cavity just happened to be in the wrong place. Similarly, you can be shot. If you're shot in the extremity, you might lose your extremity. Here's someone who was shot in the humerus, okay? But you're not going to die, all right? That's anatomic location. But physical location matters too. This actually happens to be Dannemora Correctional Facility, which is about 20 miles from here. It's what's called a supermax. I don't know the details of it, but if something bad happens to you in there, you're not getting to the hospital for a long, long time. Because what happens is the ambulance goes flying up there, lights and sirens, and the ambulance pulls into a bay that is shut down on both sides. The entire ambulance gets searched underneath, inside, everywhere. Once it's deemed to be clear, they open the inside door and let it into the prison. When it comes out, it's got to go in that same spot and be researched completely before it actually leaves the prison and gets to the hospital, okay? You're talking about something that takes hours, okay, to complete. I got to tell you, this was an eye-opener. When we moved up here, we were downstate, and we moved up here, and I was in the emergency room working, and I walk in this room, and there's 4 armed guards with this guy shackled to the ER, like gurney, right? And typically, depending on what your venue is, in the emergency room, people typically defer to the emergency physician. That's just kind of the culture of the way that works. And I remember saying to these guys, this guy needs to be unshackled so I can completely evaluate him. I swear to God, man, they just were like, nope, not happening. And that was the end of that. They were not allowed. That guy, whatever that guy did or whatever, I have no idea. But medical care, depending on your location, matters, okay? I actually took care of a guy when I was working in a small hospital one time who had a front-end loader roll up onto his pelvis, okay? So now this is a normal pelvic x-ray. This happens to be a pediatric patient because you can see the open growth plates here, right? Look at this one. This is called an open book pelvic fracture, okay? So, you know, I don't want to get weird with you guys, but if you were to touch right down here, that's where those 2 bones come together. There's an area that's typically about this wide called the symphysis pubis. For that pelvis to be separated that far, these joints up here also have to be fractured. This is a massive injury that people bleed to death from, right? So I remember calling the closest trauma center and saying, hey, I got a guy who had a front end loader roll up onto his pelvis, and when I checked his pelvis, he had what's called laxity, meaning he had movement there, right? There's not supposed to be any movement. Go ahead and try to move your pelvic bones. You can't, okay? And the guy says, well, why don't you get a CAT scan? And I said, why don't you clear transfer so we can get him to your operating room? You don't keep people in places where you cannot definitively care for them. They bleed to death that way. So what you do want to be near is University of Maryland Medical Center Shock Trauma Center. That's where most residents worldwide, well, maybe not worldwide. When I was there, we had people from Australia, people from Europe. That's in Baltimore, okay? And so for our emergency medicine residency program, we spend 3 months there. All of their trauma comes in by light flight helicopter to the roof. They take everything from what's called the Beltway, Washington, D.C., Baltimore, and surrounding areas. And basically you have trauma teams of interns, residents, chief surgeons, and attending surgeons just taking turns taking patients. So that if there's such thing as a level super trauma center, that's it. Okay, that's where you want to be when bad stuff happens. To put that into something that you would need to know, all right, the golden hour. The golden hour is a big time terminology for emergency medicine. That means that if it takes longer than 60 minutes for you to get to definitive care following trauma, your morbidity and mortality increases drastically, okay? So New York State lists trauma centers by numbers from 5 to 1, okay? Level 1 trauma center means that you have on call every surgeon possible 24/7 in the hospital, sleeping in the hospital, okay? Level 1 means you have no operating room capability at all. Okay, you have a small emergency room and you transfer trauma out. That's not where you want to be, because if you go to that little one, then you got to get the person transferred to level 1, and that takes a long time. So morbid means ill. Okay, so your morbidity increases, okay, after 60 minutes. Mortality, with the combining form meaning being mort, means death. So your death rate increases too, right? So mort, mortician, mortuary, mortgage, which actually means death pledge because you pay it for pretty much for the rest of your life. Okay, that's really where that came from. So anyway, the M&M here, when you talk about an M&M, that's a morbidity and mortality conference. This is a big thing in medical internship and residency as well, okay? That's where you actually go and people talk about cases that maybe went awry or something happened really surprising. Is there a better way we could have treated this patient, or was an error made? Those are called morbidity and mortality conferences, and that's a real thing in internship and residency. And typically, if you get called to give M&M, that means somebody saw something on your charts that looked not quite right. And you will be standing here just like I am, explaining to the rest of the medical staff why you did what you did. Okay. Anyway, we talk about people needing to get to hospitals quickly. How do they do that? Well, ground ambulance, that's the most common thing, right? But also rotor wing ambulance. That's actually what it's called. We call it a helicopter. It's called rotor wing ambulance because the wing rotates. Really good. It can land and take off from almost anywhere, like the top of a building or a farm field or anything like that. But ultimately, you make calculations. You know how long your land transport is going to take. The helicopter usually doesn't stop on top of a hospital like at Maryland Shock Trauma, okay? So basically, you have these charts that say from here, the land ambulance can get there this fast, the helicopter can get there this fast, but the helicopter's going to go and stop here, then you need an ambulance to take you the short way here. And you find out ultimately what is faster. And then there's even fixed wing transport, like maybe for people in Alaska or maybe the Midwest. I don't know. I've never dealt with fixed wing transport. This is an airplane, right? You can put more people in here. You could even put, like, say, dialysis or something here. Of course, it goes very fast and very far very quickly, okay? All right, we're kind of getting to it. You guys are really patient. When someone has been shot or stabbed in the abdomen, they go to the operating room and have their abdomen. That's called a laparotomy, okay? So laparo is the combining form for abdomen. You would have already learned that otomy means to cut into, always. Craniotomy is to cut into the cranium. So laparotomy is to cut into the abdomen, because laparo is the combining form for abdomen. And it's called an exploratory laparotomy because you don't know what you're going to find, okay? As opposed to someone who you know has gallbladder disease and you're going to remove the gallbladder. That's not exploratory. That's just a laparotomy, okay? You guys would get all the surgical suffixes, okay? So, for instance, plasty means surgical repair. So rhinoplasty, rhino means nose, means surgical repair of the nose, okay? Ectomy always means surgical removal. Appendectomy, surgical removal of the appendix. Spleenectomy is surgical removal of the spleen, okay? It doesn't matter what you put in front of ectomy, it means it's been surgically removed, okay? So anyway, an interesting thing that I was actually amazed in med school when I actually saw it for the first time in the operating room is what's called running the bowel. That is real terminology, that is not slang, okay? So what happens is you go in there and you're the medical student and there's people holding these retractors, but that's the medical students, okay? And the surgery's going on. And the lead surgeon wants to find out if the small intestine is okay. Now, the small intestine is held on by this thing called mesentery, which comes off the back of your abdominal wall. So it's actually very loose. This is really gross, but just to put this in perspective, I've heard, I don't know this for a fact, so I don't want to try teaching history that I don't really know about. I heard that back in the Middle Ages, they would like cut people open and let their small intestines fall to the ground to be eaten by rats, okay? Okay, so the small intestine has a ton of laxity. It really, really does, okay? And so I thought the guy was playing a joke on me, the main surgeon. I'm watching the surgery and he starts taking the small intestine out and he's going like this. And just looking at it and rolling it over. And that's called running the bowel, okay? And you have to do that. That's how you see if there's a bullet hole in the ball. You got to turn it over and you just keep pulling it. It's about 20 feet long, and you just keep doing that until you've looked at all the ball. That's called running the ball, okay? So anyway, let's see. 4 minutes. I'm going to give you guys an example of morbidity and mortality rounds. Now, this is really dramatic, and I'm going to tell you what parts of this are not really true, but this is kind of how it goes. This is from a TV show. I never watched any of these TV shows. I used to work 8, 12, or 24-hour shifts, and when I got home, I did not want to watch ER, okay? So I think this might be from Grey's Anatomy, but this is an idea of morbidity and mortality rounds. They're actually pretty brutal, academically brutal. Maybe you'll see it. We'll see. What do you think, Joel? I'm not super patient. I thought just the technology of getting it into the PowerPoint was impressive, but if it doesn't work, it did. I have tried it. It did work like on my laptop. Maybe it just takes a second to wind up or something. Is that right? Huh. Yeah, this one is a little bit longer. So any suggestions from the young tech crowd? How about this? Trevor? Here? Oh my God, young lady, I hope you're right, but I'm embarrassed if it's because I didn't hit the play button, but that's a good suggestion.
Do the fit, healthy men, running a region, myself included. By midnight, he is dead. So the purpose of today's morbidity and mortality rounds is to figure out how it happened. How did we lose this patient? Travis Spade, 31-year-old man, firefighter. Listen up. What? Listen up, right? Evidence are the only place that we have to speak freely about the mistakes that we have. Sure. We need to know what we did wrong so we don't do it again. So, what did you do wrong? You biopsy assist? That was my fault. It was miscommunication. So you didn't tell her it was a cyst, not a tumor? I was on my way to tell her. Alex, she's looking at you. You have to communicate. I know, but we had our wires crossed. She biopsied a high-density cyst. That is unacceptable. That's totally the fluid caused by a biopsy, which could easily cause a fatal reaction. I take full responsibility. No, I do. I don't think it was a slow leak that caused his death. Things went sideways during surgery. Who's the lead surgeon on it? I was. Okay, so brain crack. When you did the laparotomy, did you see any signs of the cyst had leaked? If it leaked, we wouldn't have noticed. 3 of us were just trying to keep it together. The 3 of you. I also assisted on the surgery. Why would I see your name on the medical list? That's sort of complicated. Huh. Well, you two just why don't you set the ticket up on that stage? Towel subject of parasite versus the alcohol count. Wait, stop there. That towel is bloody. Is it possible that one of you nicked a vessel during the commotion? It's possible. Dr. Lynn was holding Clarence when she faked it. Do you see the bleeding vessel during the procedure? Going really fast. Okay, if those alcohol-soaked towels were packed around an open vein or artery, then the alcohol would have entered the patient's bloodstream, which would lead to PDA and cardiac arrest. Okay, I think now is a good time to call lunch. Thank you, everyone. Well, I told her to say yes, so they're doing the autopsy right now. Okay, everyone, let's take a seat. I think we should be able to wrap this up pretty quickly. your reports on their way.
Productive lunch. Oh, wait, I'm the lead surgeon on this. You didn't get a chance to present the report. Well, I think the autopsy. Go ahead, talk. I wasn't there when the patient died, so I was where were you? I was at home. You were the patient?
A few times.
Fell asleep. And for a moment, I wake you up. When I left, my patient was alive. I haven't been sleeping lately. So did you run the phone? It's okay to remove and it doesn't matter. There was alcohol in his blood, nothing I could have done.
Yeah, but still, if you had responded to Alice's pages, you might have been able to help her.
You know what it's like trying to be everywhere at the same time. I can't cut myself in two.
Lose. But there's already one left half, the other half of the one that Victor's from. Hold on a second, everyone. Excuse me.
The loops were marking the vessels. They were squeezing them shut, so even if I left one in, I wouldn't kill the patient.
Yes, it would. The autopsy reports that there was no alcohol in the patient's blood, and the cause of death is sepsis secondary to biliary obstruction. Final death was awkwardness.
No way.
All right, so that's dramatic. That's a TV show. You know what I mean? Like it's meant to be dramatic. Some of their terminology made sense. It didn't all make sense as to what actually happened. And it doesn't happen in real time that I ever saw in 3 years, okay, during training. It's usually a couple weeks later. Like this, like tests coming back during morbidity and mortality rounds is absurd, okay? All the data is in, it's been reviewed, people get to look at it, and then come and talk about it. Now, people do things different ways. For instance, internal medicine, like your internist, your primary care doctor. People in different groups, on average, not every individual, have different personalities. Surgeons can be very full of themselves, okay, to say the least, okay? And so and when you're an intern, you're on surgery for 3 months, then you're on medicine for 3 months, then you're on obstetrics for 3 months, and you go to surgery grand rounds, and it's like a Shark Tank. I mean, they're just chewing each other to shreds. You go to the medicine grand rounds, and they're like, oh, interesting, I'm not sure really what happened, but maybe next time we can try. You know what I mean? There's just different ways that people communicate with each other, okay? Also, that's interesting because that shows the captain of the ship doctrine, which is true in the OR. So that last fellow who was the lead surgeon, everybody was like giving him the heat. He wasn't even there. But because he was the lead surgeon, he is responsible for the outcome of that patient. That's why it was kind of maybe seemed strange why they were focusing on him, even though he wasn't there when the surgical procedure even finished. So that's a reasonable approximation of M&M, which now you know means morbidity and mortality. Usually mortality. That's how it gets into M&M, okay? So anyway, then I usually finish with a little bit of a teaser slide. We know that kinetic energy equals half mass times velocity. And on the next class, I would tell you about this case, which is also a real case. Does anybody have any questions about anything? That's all I have for you. Thank you for coming. I'm glad to have some live people in the class because I'm not so good on camera. Young lady, what do you got? What's that?
You said that class you're teaching is next semester here?
That's the plan. I have to fill out this paper called an MCO. I don't even understand some of the words on it. Okay, you know what I mean? So I'm still looking at it. But the goal is that Dr. Slish says he's going to help me. I'm going to ask him to help me a lot, like maybe do it. He's hopefully listening to me right now. But the idea is that this class has already been cleared by Dr. Buckley to be a class in the spring.
Would that be part of the biomed major? Is that practice, or is that not known?
That's a great question, and Dr. Slish or Buckley would know the answer to that. Like, I literally just walk right now. Okay, let me clarify that. So in case any of you heard, if you're biomed majors, right now I'm teaching this class called Practicing Medicine. Okay, it's a 1-credit class where we just talk about cases and have a good time. Okay, it's really simple and easy. That class is going to be no more because I'm pulling all that interesting content into this class. But basically, as of now, I drive in here, I teach a 1-hour class, I only know how to find one room, and then I leave. All these things about which major is it and all that stuff, not a clue. Okay, anything else? All right, thank you guys. That's been awesome. If anybody has anything they want to ask non-publicly, you're welcome to come down.